labor hereditary optic neuropathy. Dr. Carden showed you the most beautiful pictures of labor today that I've ever seen. Mine are not as good as that, but hopefully they will convey the message here. So labor is, the typical labor case is a young male in the 10 to 25 year range, and they have acute or subacute onset of loss. So it's not, they don't wake up with it one day. It's something that develops over a few days to weeks. It's generally painless. It's often severe. So the central loss, severe central scotoma, relatively severe secocentral scotoma. And in the classic case, the second eye becomes involved within weeks to months. So that's kind of the textbook labor hereditary optic neuropathy history and fields. Here's the textbook clinical appearance of the disc. So it's swelling, but it's mostly nerve fiber layer swelling. It's not true disc edema in which there's leakage from the nerve. I'll show you that. But you'll see parapapillary and papillary telangiectatic vessels. You'll see dilation and tortuosity of the mid-sized arterioles as well. And you'll see this blurring of the disc that extends down the arcuate, superior and inferior arcuate regions. There's another example of this. This is a labor case that's developing atrophy already, but you can still see this very prominent thickening of the superior and inferior arcades here, with relative damage here in the papillomacular bundle already. But labor can show up as a normal optic disc, and this is something we didn't know until probably 5-10 years ago. We thought everybody with labor had that classic appearance, but not uncommon at all for labor to present with a normal optic disc appearance. Fluorescein angiography, even in the ones that are sort of markedly swollen like this, no leakage. 50 seconds into the fluorescein, no leakage at all. If this were true edema from papillitis, that would be leaking immensely.
Can it occur in the older people also?
It can. The classic is this, but I'll show you. It's been reported up to 80 years of age. Not common, but. So typically for labor, in 4 to 8 weeks, all of that, if there's swelling at the start, it will go away. If it's normal at the start, the normal will go away and it'll become atrophic. So that's the typical scenario. It ends up looking like this. This is about 8 weeks into labor hereditary optic neuropathy. Overall, they will improve in about 10 to 20%. The most common genetic mutation, the 11778, is the less common to improve. So it's the worst prognosis, the most common occurrence. And the opposite of that is the 14484, more commonly improves, but it's much less common to develop at all. Overall, 10 to 20% or so will get some better over time. So here's the atypical part. As I said, up to 40%, maybe more, depending on who you read, are going to have a normal optic disc at the start. Women can be affected, so it's not only men. The minority are women. Age up to 65, I've seen a report now up to 80 in some cases. It may be progressive over months rather than this acute or subacute discrete episode. So some of these cases just keep worsening over 1 or 2 months, usually sometimes slower than that. And the duration to the second eye involvement, so occasionally these cases are simultaneous, not common. Most common they have this sequential within a few weeks to a month. Some of them, it's a long time. There have been reports of 8 years, one eye and then the other eye going on. And very rarely, it's only one eye. So it could be all over the place. I mean, we have this classic scenario that we talk about, but there's a lot of variation in the way that labor presents. It's a mitochondrial DNA mutation. I won't spend much time on genetics because I don't know much about genetics. But you should remember this part. The most common is the 11778 position. It's an adenine to guanine substitution. It makes a conversion of the amino acids. And there are the two less common but known mutations are the 14484 and the 3460 positions. And the mutation results in impaired ATP production, basically, and the most energy-dependent cells become dysfunctional. And in this case, one of the most energy-dependent is this optic nerve region. Female transmission, it's a mitochondrial DNA disorder, so women transmit the disease to their son 50%. No transmission via males. The amount of abnormal DNA varies. So the disease state that you see clinically will vary depending on how much of the DNA is mutated. So that can vary in the severity of the clinical presentation, whether both eyes are involved, and so forth. And here's the thing that I would remind you about. We don't really understand all the inheritance patterns for this. We talk about the maternally inherited disorder. A lot of cases, there's no family history, nothing documented in the family history. So there's a lot of this that is still not clear about pathogenesis and about how it's inherited. It's rare, but it's not that rare. You know, the prevalence in Patrick E. Wyman's English series, about 3 per 100,000, 70 cases per 2 million. Retinitis pigmentosa is estimated at about 21 per 100,000. NAION incidence at about 2 per 100,000 per year. So it's right, it's kind of in this range, not as common as retinitis pigmentosa, but not super rare. You probably will see it in your career. So there's a couple of important clinical features about this. Number one is it kind of looks like optic neuritis. There are some differences. So it's painless for the most part, and most typical MS-related optic neuritis has pain. So if you've got an acute optic neuropathy or a subacute optic neuropathy and it's painless, this should come to mind. You should start thinking about the features of this. Again, it's usually male, whereas optic neuritis, the MS-related type, usually female. There's sequential bilateral involvement or simultaneous involvement, and that's unusual for demyelinated optic neuritis. It has an unusual form of disc swelling, doesn't look like the disc swelling of optic neuritis. Poor recovery, as opposed to optic neuritis, which usually recovers. And steroids don't help this. So it's important to kind of keep in mind optic neuritis and not make the mistake of calling it optic neuritis and going down the wrong treatment pathway. So it's a mitochondrial respiratory chain disease, basically. So that mutation that I was showing you affects complex 1. You got reduced ATP synthesis, increased oxidative stress, increased reactive oxygen species, resulting in apoptosis of the retinal ganglion cells. Complex cartoon that you can't see from the back of the room, but that's the essential part of it. So, should be able to treat it. If you can improve mitochondrial metabolism, reduce reactive oxygen species, eliminate the apoptosis, sounds pretty simple to treat, right? So, what's been tried? Brimonidine has been tried. Dr. Newman from Emory headed up a study a few years ago, and brimonidine, we were thinking about topical brimonidine for a bunch of optic neuropathies. We looked at it for ischemic optic neuropathy. There was good evidence that if you put topical brimonidine on the eye, enough of it gets to the back of the eye that you can activate the processes back at the optic nerve and get the effect that you see in the lab, like you do with any neuroprotective agent. So there was some evidence that putting a topical medication on could do it. Didn't work for ischemic optic neuropathy. This study also did not work. They had a lot of trouble recruiting for this study, but it was a randomized trial looking at, you put the brimonidine in the second eye after the first eye has been affected, can you reduce the development of fellow eye involvement? They only got 9 patients in, but it didn't work, basically. So topical brimonidine, no good. So here is one of the 2 things that is being looked at carefully now. Idebenone. It's a coenzyme Q10 analog, facilitates bypass of that complex 1 in the respiratory chain. So the idebenone theoretically enables you to bypass the defect and improve your ATP production in this scenario. It's been studied. There was a big clinical trial published in 2011 called the RODOS study, randomized clinical trial in Europe and Canada. The bottom line from this study is that they looked at using idebenone 900 milligrams a day for 2 years, and they allowed patients in there who had had visual loss up to 5 years prior, so it was not an early treatment for the disorder. But they used a relatively high dose of idebenone, and the primary endpoint was best recovery of visual acuity from baseline to 2 years, and it did not reach the significance that it was supposed to. So the main primary endpoint of the study was not satisfied. as far as benefit for using idebenone in labor. They did a lot of subgroup analysis in this study, and they managed to, by manipulating the data enough, get some areas that looked like there was a significant trend, and that was encouraging. Side effects were minimal. There weren't really problems with using the drug. So since then, and in parallel, some other major investigators for labor, Valerio Carelli, who's in Bologna, and Alfredo Sadun, who's with us at UCLA, have looked at various smaller, not prospective clinical trials, but looked at the effects of idebenone or different forms of idebenone, and have shown suggestions that the eventual outcome may be better. And their proposals are that you really need to treat labor patients for a long time before you see any result. You know, the ROTO study just looked at short-term follow-up. They're saying that you need to take the drug 2-3 years or more, and as you take it that long, you start to see a difference between the treated and the untreated, and the treated have more benefit for visual outcome. There is a divergence there, and the treatment group is better, but the difference in acuity really is not really dramatic. So in 2016, Klopstock, the same person who was running that ROTO study, looked at an expanded access program, a 3-year program, 93 patients on the same high dose of idebenone a day. And they did get an improvement of at least 10 letters on the ETDRS chart. So that's not as good as we usually talk about. We usually talk about three lines or 15 letters. So not as good as that, but some suggestion of benefit. And so more recently in 2016, there's been a consensus guideline for labor patients that you should treat with 900 milligrams a day if you catch them within 12 months of onset. And you should treat them for a few years. And that is the European consensus guideline, as far as I know, up to now. It's available commercially in Europe. It's very expensive. It's not available in the US yet. And we'll see what happens with that over time. We still tell our patients that they need to use idebenone, that they should go on the internet and find a drug company that's going to give it to them and buy it themselves, because we can't prescribe it. So here's the last point. What about gene replacement therapy? So this is the current hot topic in the treatment of labor. Gene replacement being an indirect transfection of a DNA sequence into the nucleus via a virus. This sequence is incorporated into the mitochondria from the nucleus, and hopefully the new DNA that you inject into there and get transformed from the nucleus into the mitochondria works better than the damaged DNA. There are some animal studies from John Guy in Florida looking at the mouse model, looking at whether it's safe and whether it has a little bit of an effect. And back around 2014, his group published a lot of work which kind of was what pushed people into going ahead with treatment trials for this. Unfortunately, he has not been able to go ahead with the trial nearly as fast as this other group that I'll show you. GenSight is the group, is originally a European group from France, is doing the study now, several studies are looking at that. So it's an intravitreal injection, a single injection aimed at the nucleus again, to stimulate the production of mRNA, which induces ND4 protein synthesis, targeting to the mitochondria, improving the respiratory chain function. And they had done some animal studies that were very promising for this. So right now, the rescue and reverse trials, which have been completed as far as recruitment, they're in data analysis now, were a controlled study. The rescue study was the one that was within 6 months of loss of vision. The reverse study was within a year of loss of vision. And sham controlled injection. So they injected an eye with the drug, and they pretended to inject the other eye. So it was a pressure on the conjunctiva without an actual injection. Only 11,778 cases, and this study was completed with 39 in one study, 37 in the other, randomized patients, and looking at the endpoint at week 48 to see whether there was an improvement of vision compared to the control eyes. Data are currently in analysis. We don't have the results of this yet. And they have also begun a second trial, mandated by the FDA actually, to require that the injections are done in both eyes. instead of having a sham eye, they wanted to have a better control situation to see whether there was really a difference. So now the REFLECT trial is in progress. More sites actually, again only 11,778, within a year of loss of vision and receiving bilateral injections, one placebo, one agent, and looking at the endpoints at 1 year. Looking also at efficacy and safety, but the safety part of this looks like it's okay for this disorder. So stay tuned for treatment. In the next year, you're going to find out the results of that first trial. So I'll stop there and ask if there are any questions about IIH or labor. It's late in the day. Nobody has any questions at 5 o'clock.
Okay, thank you very much, Tony.